Please allow me to welcome and introduce our next speaker, Professor Jorge Hidalgo. Professor Jorge Hidalgo is a professor of critical care medicine. He's also the Secretary General of the World Federation of Intensive Care Medicine, head of the Intensive Care Unit and COVID-19 Unit, Belize Health Care Partner Limited in Belize. He's a member of the Society of Critical Care Medicine, author of many chapters on critical care obstetrics, editor of the Obstetric Catastrophes, among other books. Tonight, he will shed some light on another important topic, which is the physiologic changes during pregnancy. Professor Jorge, please go ahead.
Just first of all, I would like to thank you for the invitation to be part of this excellent academic effort. I just want to prepare my slides to be able to share. And I also have the pleasure to know some of the excellent panelists and also of the board committee. And I know that that essentially speaks about the high level of the academia that this courses is offering. And I just want to thank you to allow me to contribute in a small part to this excellent effort. In that I will share in the following half an hour some of the initial part of a series on the management of the clinical obstetric patients, especially the one that is critically ill. And as you will agree, the management of the critically ill patients right now in our era is essentially managed by a group of specialists. Essentially, what we are going to cover today is the part like us as an intensivist contribute, but most of the time, as you know, we will have an obstetrician and a perinatologist and other group of support in the management of this kind of patients. No, I mean that saying that the idea is to change in this series is to start with all with the basics. Mean that we will review some of the physiological changes that are important to know during pregnancy. And I don't have no conflict of interest in this presentation. And the idea is to try to, the following half an hour is to try to identify the physiological changes in pregnancy, see how those adaptations are going to affect and interfere with our diagnosis and management to our patients. And of course, with the idea that those identifying those changes, it will allow us to anticipate the effects on pregnancy or a new underlying medical condition and see how this process is affecting the patient. You know? I mean that, as we know, the physiological changes during pregnancy will allow the development and protection, and also to prepare the patient for labor and also to compensate for the new demands. As we know, pregnancy can mask or aggravate pre-existing diseases, and we must recognize normal physiology that occurred during pregnancy, and essentially with the intention at the end of the day, as everything we do in medicine, to optimize the outcomes and offer the best outcome for the patients. Being that, saying that, we will start initially with the hematologic changes during pregnancy. And as we know, we will see some changes in several aspects of the hematological changes, and some of them essentially are the maternal blood volume. And as we know, we will see an increase of the plasma volume during pregnancy, and this involves increase in plasma volume as well as in the red blood cell. As we know, the plasma volume, it will increase an average of 40 to 50%, whereas the red blood cells are going to increase by probably 15 to 20%. And that essentially would lead that we know to physiological anemia or delusional anemia of pregnancy. And because of this hemodilution, then the blood viscosity will increase in plasma, and all of these mediators, such as some of the aldosterone, the progesterone, oxy nitric oxide, are essentially involved in some of these changes. No, of course, there are many hypotheses as what probably are most of the hormones related, and then we see that essentially is the state that initial vasodilation will stimulate by the renin, angiotensin, and aldosterone, that it will cause essentially a fluid retention. Alternative, some authors are proposing overfill that is essentially characterized by sodium retention due to an increase in mineralocorticoids that leads to fluid retention, and essentially it will cause an increase in blood volume followed by a vasodilation. The blood volume will increase also a little bit further during the labor, and as the uterine contraction squeeze out the blood in the intervenous space in the central circulation. After delivery, the involution of the uterus and, of course, the termination of the placental circulation causes an autotransfusion of approximately, we can say, 500 ml of blood. And then some of the changes we will see also is we'll notice on as based on all of this a blood viscosity reduction in 20%. We can probably notice on increases in the white blood cell count as well. No? The other thing we will see is that we will notice some changes in platelets, changes in clotting factors, and this have an important understanding, especially when we're talking about the hypercoagulant effects of pregnancy. You know, I mean that as we see mentioned right here, and we will discuss it right now, changes in platelets, changes in the predisposition of clots, some of the increasing on this factor as well as some of the proteins. It will favor all these hypercoagulable state. The levels of clotins 1, 7, 8, 9, 10, and 12, and fibrinogen during pregnancy, we will see elevated platelet production. Also, it will be affected. It will increase, and also the levels of the thrombopoietin. Platelet aggregation in vitro is also likely to increase. The overall effect of these changes, it will at the end of the day, it will affect the amount of platelets. Probably we'll see some reduction of platelets at the beginning in 150,000 in some probably 7% of the patients, and probably less 1% of the pregnant patients. You will have a platelets numbers that will basically range around 100,000 at the term. No? And of course, understanding what is happening, some endogenous anticoagulants such as protein C are decreasing normal pregnancy, and there is an quite resistant to the activated protein C, uh, and all those are going to essentially contribute to the prothrombotic effect. The fibrinolysis is also impaired during pregnancy due to a placental derived plasminogen activator inhibitor, but it will return to normal after the placenta is delivered. No? The overall indices of the coagulation indicate that normal pregnancy, as we mentioned, it have an hypercoagulable state. No? Now, what is important for us to know that, because if essentially what we want to know is what are the clinical implication of those. An increase of blood volume and an enhance of the coagulation serve several important functions, and one is to increase the circulatory needs of the enlarging uterus and growing fetus and placenta, and are met second in the parturient, and is protected from protects the patient essentially for bleeding at the time of delivery. I mean, that those are the things that we need to know when we are called to ask for our opinion in the management of those patients, because having that in mind, then we need to be very careful, especially when it comes to the decision to the fluid that we are going to administer to these patients. No? Also, we know that pregnancy become an hypercoagulable state as gestation progress, and the chances of thromboembolism are always there. I mean that that's some of the clinical aspects that we need to have in mind when we are discussing uh, those time of hematologic changes during pregnancy. The other important aspect that we need to also have in mind is what the different changes in the cardiovascular system that we need to have in mind. We see that immediately we will see in those patients an increase in the cardiac output as one of the most important changes in pregnancy. And as we mentioned in the slide, the cardiac output is going to increase in 40 to 50%, and he will probably get his maximum in the around 24-week of gestation. No? Also, we need to see an increase in the heart rate that occurs at the beginning of the pregnancy, but also we'll see that it will increase as the pregnancy progresses, and it can go up to 20%. The stroke volume also it will increase, and we will see that it will go up to 30%. No? Some of the, especially those that we will use a lot, the echocardiography at the bedside, we see that the echocardiography will demonstrate an increase in the end diastolic chamber size and probably the left ventricle wall thickness some, but there's not going to be changes in the end diastolic volume. No? We can probably see some increase in the ejection fraction. Some of the things that we need to know or we need to remember when we are doing echocardiograms at the bedside. The cardiac output, of course, it will vary depending on the uterus size, maternal position, and the time of measure. The enlarged gravid uterus also is something that we need to have in consideration, because it can cause aortocaval compression and reducing the cardiac filling while the pregnant woman is in supine position, leading to essentially an underestimation of the cardiac function. Those are the some of the things. Some of the other, we will see that we are going to see a reduction on the systemic vascular resistance by 30%. Also, we will see some changes in systolic and diastolic blood pressure in an average of 8 to 20%. No? The film pressure, especially the CVP, the pulmonary, the capillary wedge pressure, the left ventricle end diastolic pressure, do not change despite the increase in cardiac dimension. Of course, we see due to myocardial remodeling during gestation. No? The systemic vascular resistance, as I mentioned, it will decrease. And those are some of the aspects or considerations that we need to know in the patients, especially with the cardiovascular uh, system. No? Also, the heart is going to be displaced to the left during pregnancy, and is something that we need to have in mind, as well as especially in the electrocardiogram, we can see some sinus tachycardia, some benign dysrhythmias, probably some mild depression in the ST segments and flattening of the T waves. We can see also deviation of the left axis and some left ventricular hypertrophy. No? Mean that in terms of the clinical implications, as an increase, the cardiac output may be no well tolerated by pregnant women, especially those that have a heart diseases. Patient with aortic or mitral stenosis probably will have some problems to adaptate. No? And the compensation in myocardial function can develop uh, 24 gestation during labor and especially immediately or after the delivery. No? I mean that those are some of the considerations that we need to have, especially when we are discussing the changes in the circulatory system. No? I mean that let's see how this translates into the effects during the labor. No? In each uterine contraction, we'll see a return of 300 or 500 ml of blood to central circulation, like is going to increase the maternal cardiac output. No? Also, we will notice an increase in the venous return during the uterine contraction that can lead to transient maternal tachycardia. And also, we can, in second stage of labor, the pushings, it will intensify the cardiac output to 50%. Other effects is that the blood pressure will increase, and especially preceding to contraction by 8 seconds from cardiac output increase. Those changes are less pronounced when patient is in the left lateral decubitus position. Oxygen consumption increase more or less 3 times during contractions. No? In an immediate postnatal period, the cardiac output increase 60 to 80 and stabilizing in the first hour postpartum. No? The postpartum cardiac output increase is due to autotransfusion phenomenon, and the uterine blood volume decrease uterus and is not longer compressed for the vena cava. No? The postpartum diuresis occurs between days 2 and the 5th day. The other important aspect that we need to know is what are those changes that we will notice in the respiratory system that we need to know, because of course it will interfere, especially if we need to make any decisions, if patient needs to be ventilated, or especially in the interpretation on the volumes as well as ABGs that we need to have in mind. No? And as we know, the changes in the respiratory parameters start as early as the 4th week of gestation, and one of the most important one is the minute ventilation that is increased at term about 30 to 50%. And the increase in minute ventilation is mainly due to an increase in the tidal volume, no more or less an average of 40%. And in some extent also is affected and by the increase in the respiratory rate that we see in average of 15%. No? Alveolar ventilation is greatly increased as the tidal volume increases, no, without any changes. No, the other important thing, changes that we will notice is like the PCO2 that decreases to 32 to 45 millimeters in mercury, and we need to have that in mind, and especially when we are interpreting ABGs. No? Oxygen consumption and carbon dioxide production increases by 60% in average in pregnancy. The PO2 is increased in early pregnancy due to the decrease in PCO2. The other aspects that we need to have in mind is the changes in the different volumes. No, we see changes in the functional residual capacity, the expiratory reserve volume and residual volume are decreased at term. And then, of course, we need to know that these changes are related to cephalate displacement of the diaphragm by the large gravity uterus. No? The inspiratory capacity also increases somewhat because of the increase in tidal volume and the respiratory reserve volume. The vital capacity is unchanged. The total lung capacity is only slightly uh, reduced because the circumference of the chest increases. No? The closing capacity does not change, but the reduction in the functional residual capacity contribute, in a sense, to tendency toward earlier uh, desaturation, as lungs are more easily to fall. No? I mean, that those are some of the important considerations that we need to have in especially for volumes. And of course, the clinical implications that those have is that the decrease in the functional residual capacity, as well as an increased oxygen consumption, can cause a rapid development of maternal hypoxemia during apnea. Also, the decrease on the functional residual capacity decrease the times or the nitrogen levels and speeds the uptake of some of the inhaled anesthetics. No? Because of the increase on the edema, the vascularity, and also the friability on the mucous membranes. Also, one of the things we need to have in mind is that, especially when we are manipulating the oral way, we need to use probably when we're trying to intubate, we need to use tubes of the less sizes. No, normally 6.5 or 7. No, and also in terms of the gases, no, we see changes in gases, and maternal alkalosis is associated with a decreased PCO2 values due to hyperventilation as a it could be basically as a result of labor pain, or also no. We see changes also as well as in the numbers of the bicarbonate to approximate it 25 could be probably normal to 23 to 22 in some of those patients. I mean that those are the numbers that we need to have in consideration, especially when we are trying to analyze blood gases in patients, in the pregnant patients. I mean that as we know, the oxygen consumption, it will increase to 30 to 50. There are two-thirds for the mother requirement, and it's also going to increase oxygen consumption. It's going to the reduction on the functional residual capacity is essentially is causing to the mother is going to be more susceptible to hypoxemia during periods of apnea, or especially during attempts of endotracheal intubation. And there are some of the aspects that we need to have in consideration, especially when we are manipulating an airway in the patient, in the pregnant woman. No? The other also aspect that we need to have in consideration is the gastrointestinal changes. No, we see an increase in the size of the uterus that displaces, and then the lower esophageal sphincter, the progesterone we know that relaxes uh, this high pressure zone, causing a progressive increase in the incidence of heartburns. Essentially probably can be as bad as 80% at the term, as well as gastric pressure due to mechanical compression, and that can essentially uh, contribute and increases the chances of aspiration. Or that's we need to have that in consideration. No? Also, we can see some elevation in the liver enzymes, especially transaminasemia. We can see also elevation of the alkaline phosphatase, but most of the time, those elevations are going to be related most to the placental production. No? Uh, we also will see some important elevations in the serum cholinesterase activity that is reduced to 24% before delivery, and probably can reach a nadir of 33% in the postpartum day, and approximately an 11%, no, in the postpartum woman. And then those even is important when this lower activity, especially when we are dosing or using succinylcholine for intubation. No? I mean that some those changes in succinyl in the succinyl in the cholinesterase activity, we need to have it in mind when we are calculating succinylcholine. The other important aspect are the renal changes. No, in the pregnant woman, we know that we will see some important uh, renal changes. We will see an increase in the size of the kidney. We know that we are going to be a pelvic-calyceal dilatations, predominant in the right more than the left, hydronephrosis most in the right side than the left, an increase in the glomerular basement membrane, pore size and electrical charges, afferent and efferent arterial dilatation. The glomerular filtration rate is increased during pregnancy because of an increase in the renal plasma flow, and also a raise in the filtration rate, decreased plasma blood nitrogen, and the creatinine concentrations by about 50%. I mean that those are an important aspect, because we see that the creatinine levels are going to be low, and then that is essentially an important number for us to have in mind, especially when we are interpreting creatinine and BUN in the context of patients with acute kidney failure. No? The tubular reabsorption of sodium is increased. However, glucose and amino acids are not going to be absorbed as efficiently. We can see some glycosuria. No? The renal pelvis and the ureters are dilated, and peristalsis is decreased. We see some physiological diuresis during postpartum period, and the glomerular filtration rate and BUN concentration is going to be a slowly return to non-pregnant values more or less in 6 postpartum weeks. No, we see some changes in the renal hemodynamics, also in the glomerular function that we will analyze. Um, and of course that essentially it will have some implications. We see changes in tubular function. We also see some changes in the endocrine function of the kidneys that is critical. Now we'll see some patients with certain uh, predisposition to urinary tract infections, and also as we see some increases in the plasma creatinine, and most of the time we are called to discuss acute kidney failure, and also we need to have those aspects in mind when we are seeing changes, or we will see in patients in the ICU, or in the critical areas for the obstetric patients. Just to emphasize in the changes in particular of the creatinine uh, for the pregnant women, and also the increase in the renal blood flow, also increase in the glomerular filtration rate by 40 to 50%. That can have some clinical implications. No, mean that this is something that we need to have in consideration, that during pregnancy and the postpartum, the physiological changes occur to facilitate the mother, and as well as the baby, to adaptate to the increased metabolic needs, and also to enabling adequate delivery of oxygenated blood to peripheral tissue and the fetus. And that this is the first part of a series of lectures that we're going to have an opportunity to discuss in this forum. Um, and again, thank you for the invitation. And I'll be in contact with you. This is my email and my different contacts.
Thank you very much, Professor Jorge, for your presentation. I believe it's important to have a refresher from time to time. Thank you. Um, I don't think we have any questions for you. So I believe this would bring us to the end of our session tonight. Um, thank you very much, dear speakers, for your presentation and participation tonight. Thank you very much, dear panelists and attendees, for your time. And I hope you enjoyed your time with us tonight. Um, Goodbye and see you next time.
Thank you
Thank you
very
very
much,
much.
everybody. Thank you very much for participation and looking forward to see you again. Thank you.
Thank
Enjoy
you. You
your
have
evening.
a
Thank,
nice day.
Bye bye.
Thank you.